Welcome, and thank you for joining us today for this session from the BHF Data Science Centre entitled, Could Your Smartphone Help Diagnose Heart Disease? This is a summary of the session format for today. I'll first be introducing our speakers, and then we'll be moving on to bite-sized presentations. We'll then be having a question and answer session where attendees will have the opportunity to ask questions and share their thoughts. To introduce myself, I'm Jackie MacArthur, and I'm a research project manager with the BHF Data Science Centre. I'll be chairing the session today and keeping everything on track. This is Tim Chico, who will be speaking today. Tim is a consultant cardiologist and Professor of Cardiovascular Medicine at the University of Sheffield. He's also lead of the Personal Monitoring Data Theme and Associate Director at the BHF Data Science Centre. Myra will also be joining us today. Myra is Public and Patient Involvement and Engagement Manager at the BHF Data Science Centre. And representing our public and patient partner group, we'll be joined by Helen and Anwar. Before we start, I'm going to briefly introduce the BHF Data Science Centre. The BHF Data Science Centre was officially launched on the 1st of January 2020. It's a partnership between Health Data Research UK and the British Heart Foundation. Our vision is to improve cardiovascular health of the nation using the power of large-scale data across the UK. Part of this work is around using data from smartphones or smartwatches to improve the understanding or diagnosis of cardiovascular disease. Tim's going to be talking about this today. I'll pass over to Tim now.
Thanks so much, Jackie, and thanks everyone for joining. We'd like this to be the start of a conversation about how information from smartphones might be used to improve the way we diagnose heart disease. So, just to be clear, diagnosis is what a healthcare professional, a doctor, a nurse, a paramedic, or other professionals does to try and understand whether someone has a disease and what disease they might have from its signs and its symptoms. Now, symptoms are the things that are the negative experiences that a person is feeling, that are usually the main reason that they seek medical attention in the first place. I think that probably everyone is now aware that sensations of discomfort or pain or heaviness in the chest can be a symptom of possible underlying heart disease. It's a bit less frequently appreciated that a sensation of feeling breathless can also be a symptom of possible underlying heart disease. And there are a range of other symptoms, such as an awareness that your heart rate is either too fast or too slow, or dizziness or blackouts, that might indicate underlying heart problems. So my first question, and to remind you, your responses are anonymous and you don't have to answer if you don't want to, but have you ever seen a doctor about symptoms of possible heart disease? Yes, no, or not sure. And we'll give you a bit of time to decide if you want to answer, and to get your answers in. We have no preference as to which category people are in. And there we have, so you should be able to see the results, which is about a third of people have seen a doctor with these kind of symptoms. So, although chest discomfort might be a sign of underlying heart disease, it affects at least a quarter of all adults and is usually, thankfully, not a sign of underlying heart disease. Whilst breathlessness can, of course, be completely normal, depending on what level of exertion we're talking about, what level of physical fitness one has, other medical problems. So this usually is not a sign of heart disease either. So given how common these symptoms are, how do doctors tell whether or not these common symptoms might indicate heart disease? Well, doctors and other clinicians work a bit like computers. They take in information or data and they process it in their mind to produce a decision. And that decision might be what diagnosis someone might have, whether or not someone needs referral to specialist services, whether they need tests, what treatments might be required, and so on and so on. Now, just like a computer, if the information in isn't accurate or is incomplete, then the decisions that come out are inaccurate or incomplete. Now, in terms of the information that's used, there's lots of different types. As you'd expect, given that the reason people tend to be in front of me or other colleagues is because of the symptoms they're getting, we want to know as much as possible about what it is the person is experiencing. But because heart disease is so closely linked to physical activity, not just because if you don't do enough physical activity, you have higher risk of heart disease, but when you develop heart disease, your ability to do physical activity tends to decline. We're very keen on understanding and as much information as possible about what someone can do, its relationship to their symptoms, etc. But there's lots of other information which is required. Someone's medical history is key in working out what their risk is of having heart disease in the first place. Examination, physical examination with stethoscopes and those kind of approaches are sometimes important, clearly harder under remote consultation circumstances, which makes it even more important to get the right information in other ways. The previous test someone has had may give information, and future tests or further tests might be required. So that's the information that comes from the individual, but there's lots of other information that the doctor uses to compare that against. A lot of that comes from the training. So how long someone's been training for, how they've been trained. This changes the way that we use information. And to be honest, experience is key. Recognizing disease if you've never seen it before is quite hard, whereas recognizing it when you've seen it a lot before becomes much easier. So I've been training as a cardiologist for over 20 years. I've got better at recognizing things that I've seen before. I would be useless treating patients with other kinds of conditions because I don't have the training and I don't have the experience. So my next question is, in your personal experience, and there's no right or wrong answer, could diagnosis of heart disease be improved compared to how it is today? And we'll give you a few moments to complete that. As I say, no right or wrong answer, but it would just be useful to know. So 83% of people feel it could be improved, 18% not sure. Absolutely no one, not even the cardiologist, thinks that it's fine at the moment. And that's really important to take into account when we're talking about what we do from here. I would agree that accepting the status quo is not ideal. And that's borne out by the evidence. So heart failure is a condition which affects at least 1 million people in this country, which causes breathlessness on exertion. And yet 80% of the people who are diagnosed as having heart failure are only diagnosed after they've been admitted to hospital as an emergency, even though many of them have seen their doctors in the weeks or even months or years before that diagnosis, explaining that they've got a problem, and yet it is still diagnosed too late. Why is this? Why are we not diagnosing disease as quickly and accurately as we would want to? Well, I've explained how important it is for the information that goes in to be accurate and complete. And I've also explained why, symptoms are the most important thing to the patient or the person. And yet we don't measure them. Those of you who've seen a doctor about this will know that we tried to get this information by asking lots of different questions. When did the symptoms start? How often do they happen? How long have they been going on for? What do they feel like? What makes them worse? What makes them better? What time of day does it happen? Etc., etc. This is a very difficult process. It's particularly difficult if the patient or the person has problems remembering how long something's been going on for, how often it happens. It's very difficult if the person doesn't speak English and you have to use a translator or an interpreter. It's very difficult if people are daunted by medical consultations, and it's very difficult to do it in a short period of time, which is, of course, largely what we have within current healthcare systems. So this is a big problem if we really want to understand what people are experiencing. I've said that activity is really important, and we still don't measure this either. So we base this again on people's responses to questions. How far can you walk? How many stairs can you do? This is a very inaccurate process. Clearly, we often find it hard not to make judgments just based on how someone appears, but appearances are deceptive. Just what someone says, just how someone appears, that really doesn't give us enough information about someone's cardiovascular health. So this process of expecting the patient and the person to come into clinic and tell you the information you need is badly flawed. It's like if you had a car that was breaking down, and instead of taking your car to the garage, you went in and described to the mechanic, oh, it sounds a bit like this, or, this is what's going on, and expect for the mechanic to just go, oh yeah, this is the problem. That doesn't work for cars, and this is very unlikely to be the right way forward for medicine either. So that brings us on to the subject of this talk, which is smartphones. It's definite that these technologies can obtain information that doctors currently don't have, but almost certainly need to improve the way we look after patients. The kinds of information they can obtain are, for example, on someone's symptoms. So there and then, when a symptom happens, the person can record them so we know when it's happening, how often it's happening, and what context. They can measure someone's activity, how far and fast they can walk, how easy they find it to go up and down stairs, whether this is getting worse or better over time. They allow us to understand someone's environment. And there are many ways now that we can obtain information that we would only previously have got in hospital or in clinic in terms of heart rate, ECG, blood pressure, etc. Particularly important if we can't examine people if they're not in front of us at the time. So my next question is, do you own any of these devices? And you may be able to select more than one. Do you have a smartphone? So that's a phone which can connect to the internet. Do you own a smartwatch? So that is something on your wrist that does more than tell the time, but it acquires information, say, on what physical activity you do, whether your heart rate. There's lots of different functions, but any of those would count as a smartwatch, or none of the above. So I'm interested to see. So that's very interesting. So 100% of everyone here owns a smartphone and 55% a smartwatch. And maybe that's what you would expect for an audience who are participating in an online discussion. So you'd kind of be forgiven for thinking that everyone's got a smartphone. Certainly everywhere you go, you can see people on their phones. But you might be surprised to hear that even in the younger age group of 18 to 25-year-olds in this Deloitte survey, only 90% of this younger age group had access to a smartphone. And it's also perhaps a surprise that that doesn't really change very much even in the 55 to 75-year-old age group. It's still about 9 out of 10. A lot of people, but not all people. And when you look at what people's income levels are, the people on the lowest level of income are less likely to have access to a smartphone than the people who are the most affluent. So if we're moving in a direction where the smartphone is used we have to be aware that not everyone has one. And you can, as you know, there are NHS services and information sources which really require access to these devices. So my next question is, how do you feel about using smartphones to improve diagnosis if not everyone owns one? Again, there's no right or wrong answer. It's a rather simplistic question, but I'm just interested in your views at this point. So that's interesting. Again, this is consistent with other surveys we've done, which is, as long as these things are beneficial to a large proportion of people, then generally speaking, people are in favor of it. But there's a reasonable reason to be either against or not sure. And in discussion with patients and the public and other stakeholders, our position in the BHF Data Science Centre is now clear. If healthcare requires these kind of devices, the healthcare system should loan them where needed. And diagnosis, actually, this is perfectly normal already to loan people technologies to help improve their diagnosis. And really, we should be diagnosing disease within a few days. So that doesn't really require a long-term loan. So, as I guess you can tell, I believe the information from these devices could be really useful, understanding someone's symptoms or activity or environment or physiology. I think they could help me make better decisions with my patients, but on their own, they are useless unless they're linked to the other information, which is also required, the medical history, the test results, the x-rays. And it's only putting these two things together, the smartphone data and the medical data, that gives us the fullest possible picture of someone's health. If we had these kinds of data, medical data from the NHS record and smartphone data, we would know who goes on to develop disease to understand risk. We would know who has what disease to understand diagnosis, and we would know who responds to different kinds of treatment. And because of all this data, we would be able to perform things like artificial intelligence or machine learning to recognize the patterns in the disease that would allow us to improve diagnosis of heart problems. So the theory is simple, but there's some important caveats. The data collected has to be representative of the whole population. If the data only came from white, affluent males, then there's absolutely no guarantee that the tools that were developed would work in other groups. It has to be accessible. People have to be able to take part if they want, and they have to understand the reasons for the study and what we would hope to achieve. And that's why conversations like this before we've done anything are so important. And the other reason to have this discussion before we do anything is it has to be acceptable. We have to explain why we would want to acquire any kinds of data like this and see whether or not people are happy to allow it to happen. So another big question, another simplified question, no right or wrong answers. How would you feel about your smartphone data being used to diagnose whether you personally have heart disease? This is a hypothetical question. We're not talking about doing this yet, but how would you feel about your smartphone data being used to diagnose whether you have heart disease? You may need to think about it. You may change your view. It's all fine. So it's interesting that no one currently feels against it and that the majority of people currently feel in favor. So last year we held a workshop of patients and doctors and scientists and the manufacturers of devices to try and understand how we can improve cardiovascular health. And the report that was published this year, and we will share the links later on so that you can look at this, and we very much value your views on it. We would like to move towards a UK-based large-scale collection of smartphone and wearable data, which is linked to NHS data, because as I've explained, unless it's linked to health data, it really isn't useful to try and improve health. The way it would work would be something like this. We're used already to the fact that when we need NHS healthcare, lots of data are collected in routine healthcare, and that's kept within the NHS, and it's also transferred to NHS Digital. In a research study, we would want people's permission, their consent, to collect some of the data from their phones and perhaps some of the data from their wearables if they own any, and to store that separately from any sensitive medical information. We would want to acquire this from lots of different groups of people, people with different diseases, people from different areas, people from different regions, people from different backgrounds. So that would be keeping the very sensitive medical data separate to the smartphone and wearable data. But to make use of this, we would need to take some of the smartphone and wearable data and some of the NHS data and connect them together. And we would connect them together using someone's NHS number. And that linked data would be kept in a secure, what's called TRE, Trusted Research Environment. It doesn't allow people to see who the patients are within the trusted research environment, but it allows us to see the connection between the smartphone and the NHS data. So my next question is, would you consider taking part in a study that collected some of your smartphone data over several months and accessed your NHS data to put it into this trusted research environment to try and improve the diagnosis of others, of everyone, of future health? It wouldn't be of any direct benefit to you medically, it would be a research project. So, and there is no right or wrong answer. There's a lot more you would need to know one way or the other, but I'd be interested in your current feeling. So whatever you say is fine and valuable and valid, and so the survey results people will be able to see. I'm going to out myself and say I said not sure. I said not sure because I want to, I'd want more information, more detail to know what I was signing up to. And I'm going to finish just on the 3 key questions that we would need to address before I would be convinced. Okay. And the first is, what smartphone data are we talking about collecting? I've given you definitely we need to be something about symptoms, something about activity and environment and physiology, but exactly what? Who should we aim to recruit? What types of diseases, what types of people must we make sure are included in order to be representative? And crucially, what safeguards must be in place to protect our privacy, to protect the security of our data, to prevent this from being misused. And these are the things we need to address, and we will address before we do any of this. So I don't have the answers, although I'm very sure that working together, we can address all of these questions. And on that note, I'm just going to pass over to Myra, Helen, and Anwar. Thank you so much for listening.
Thank you, Tim. So hi everyone, my name's Myra Khan and I'm the Public Involvement Manager for the Data Science Centre. So my role is all about involving members of the public like yourselves in our research at the Data Science Centre. So what do we actually mean by patient and public involvement? So there's lots of different definitions out there for what we mean by PPI, and the one what we use is this one by the National Institute of Health Research, that research carried out with or by members of the public rather than to, about or for them. So it's about actively involving members of the public like yourselves in the research process and allowing you to have a decision-making impact on the actual research. So kind of like an advisor role on the research, for example. So why do we do public involvement? So lots of different reasons why we do public involvement and lots of drivers behind it. But I think one of the most important ones is the impact that it can actually have on the actual research process itself and the research. So we want to make sure that our research is relevant, and we want to make sure that we're doing it in a way which is right for our target population. So Tim touched on these areas that are absolutely crucial for public involvement, for us to be able to articulate patient benefit in our research and to really be able to have an impact. So the first one is around representative, making sure that we're as inclusive as possible, and we're thinking about different backgrounds, gender, age groups, etc. Because we know that what works for one person might not for another. So this is absolutely crucial. We want to make our research accessible. So Tim talked about that. So it's absolutely key that, we're as transparent as possible. We want people to know what we're doing and why we're doing it. So this is absolutely key for us. And then also acceptability. We want people to be able to make an informed decision and understand what they're doing and make sure things are in plain English and acceptable from a public perspective. So absolutely key. So these are all areas that are things that we're exploring with our public involvement group. And at the Data Science Centre, and for this area of work, we have developed a public involvement group with some public partners. And we've invited 2 of our public partners to the meeting today to explore their experiences and also give you guys an idea about their experiences. So I'm going to ask them a few questions, Helen and Anwar. And my first question is, what motivated you to be involved in research? And if we can start with Helen. Helen, you need to unmute yourself.
Hi, yeah, thanks, Samira. I'd say it's a pleasure to be here. What motivated me to get involved? I first got involved because I'm a big advocate in enabling people or wanting people to have enough information and tools to be able to make decisions that can enable them to manage and improve their own health. And I think that wearables have the potential to do this. I myself actually got a wearable 6 years ago, so I'm an advocate for them. And the reason why I got a wearable was because I really enjoyed exercise. I was running a lot and I wanted to really improve my fitness, but I found it had sort of wider benefits as well. So it just changed small things in my lifestyle. So where I might take a car, where I might usually take a car, I would walk, with my sleep, it made me much more aware of sort of like getting more sleep. But then in March 20, I got COVID in the first wave. And as a result of that, I got some long-term health issues around that. I got pericarditis, which is inflammation of the lining of the heart, and also irregular heartbeat, and also chronic fatigue, which I still have some issues with now. And so what I found that my Fitbit actually helped me in completely different ways, and I found it was really useful in my rehabilitation. And it enabled me to actually see kind of like what activity I was doing on a daily basis, because I had to actually manage the level of activity I was taking to stop myself crashing. It also enabled me to understand what normal looked like for me. And so when things weren't normal, I could see that. And it also was really motivating for me to see over time actually progress, so I could actually see things improving over a long period of time. So I actually found that really, really helpful and really positive. And also I used the Fitbit to convey information to my health professionals as well when it was relevant. So I really wanted to use all of that experience and knowledge that I've got to share that with the project, and to be able to bring my patient perspective for patient benefit, and in a way that hopefully will enable patients to get better treatment, diagnosis and care.
Thank you, Helen. That's great. Alan, what about Anwar, rather? What about you? What motivated you to get involved?
I think for me, there are three main reasons that motivated me to be involved. The first being that about 3 years ago, I had a cardiac problem that led to cardiac surgery. And I spent quite some time in hospital and in rehab. As a service user and a patient and a service user, I feel I have some experience in that area. I feel I got something to say. I feel I can contribute to shaping this study out. My second reason is technology. I'm a great believer in using technology. I have always taken responsibility for my own health. To that effect, I use a range of devices to monitor my health. However, I have to say, although I have a smartphone, I've never owned a wearable, so to speak. However, I also have to say that although I don't have a wearable, I have to say I think this project, the wearable project, is an exciting innovation, and that in itself is a good motivational reason to be part of this research. And finally, I also have to say that before joining the group, this project, I have been a patient and public involvement with the NIHR. So I have got some experience of contributing to patient research, and therefore that was another good motivational reason why I wanted to be here and share some of my experience.
Excellent, thank you for sharing that. So I've got a couple more questions. So Helen, why do you think that's important? Why do you think this is important? You just need to unmute, Helen.
I'm so engrossed. Yeah, I think, you know, if you look at technology over the last sort of like 5 to 10 years, I mean, there have been huge steps forward. And I think the way that sort of like smartphones, wearables have really sort of like changed what people can do. And I think I'm right in saying that there's now over 10 million people, and I think that grew over lockdown, the number of people who actually who have either a smartphone or a wearable. And I just think it's really hugely important that we could harness that information and, as Tim says, link it with healthcare data, which would enable better medical insights, so that it would enable using that data to potentially reduce risk of illness and improve diagnosis and treatment. And I think also the other benefit, I think, of this project is that I think it's about raising trust as well. So I think it's about, you know, enabling perhaps medical professionals to actually trust the data that's out there. And I think in some situations, maybe they don't. And I think also for me as a public contributor as well, to actually be involved in the project and to help ensure that the data is looked after, as Tim was talking about, to make sure that it's safeguarded, and I think that that's a key role. Another area that I think would be really beneficial, which Tim also talked about, is actually real-time data. So I think, you know, with the wearable, you know, if I've been wearing this for 5 years, potentially I've got 5 years of data here about what I'm doing. And I think quite often when you go to a medical professional, you know, you see a snapshot on a day rather than actually sort of seeing a whole history. And I think particularly for the condition that I've got, which is relapsing remitting, you know, on a particular day, it can be one way, but on another day, it can be something else. So actually getting that big picture, I think, is really important. So I think for all of those reasons, I think it's a huge benefit. Brilliant.
Thank you, Helen. Some really good points there. Anwar, what about you? Why do you think?
Yeah, I think this is a very important research. What I have already said, I think it's an exciting innovation. I see it as a novel idea, and I think if this study meets its objective, it's likely, it's possible that it can bring about early diagnosis. It can prevent long-term complications in existing patients. It can save lives, potentially save lives, prevent hospitalization. It can, I think, in the long term, it can benefit the NHS as well as patients. I also think that in time, you know, if this study is successful, we could go on to change guidelines and make it more available to a range of, make wearables more available to a range of people. Can I also say at this point that I think it's important to involve patients and the public in this in any research, and in particularly in this research. And I have been impressed with the way that the research team has worked with us from the onset, and we have been involved really well, and our views are heard. It's not, I mean, the research team just doesn't listen to us; they hear our views. So we have been heard. We are being heard, and so I think what I also think, when patients and the public are involved in research, you can produce better research. The research quality can be better. The outcome can also be better. So all in all, I think this is a very important research, and I think this study can make a difference.
Brilliant. Thank you so much for that. One more question for you guys, and I'll let you off the hook. So, Anwar, has being involved changed your views then?
Well, I have to say, you heard me a little earlier. I said I'm a great believer in technology. However, I have to say I was a skeptic, and I couldn't see the sense of a little things on your watch which cost a lot of money doing as much as it's claimed to do. However, since being involved in this study, we have been exposed to talks and workshops. We've had experts talking to us. We've had experts from Fitbit and Apple and come and talk to us. And it's really impressive, you know, the lens they're going to make the product as accurate as possible. They don't claim they're going to be 100% accurate, but they're working really hard to make it as accurate as possible. I have also seen in the media people who are wearable users, they have been notified by their wearables of cardiac abnormalities. They've been to the physician to be checked out, and those abnormalities has been confirmed. I'm also excited to hear, like Tim said, that there's a possibility that our data could be linked to healthcare professionals. As Tim said, it wouldn't be that much good if we can't link it to a healthcare professional. I think what I've heard, what I've seen, has convinced me that there is a place for wearable. It can bring about early diagnosis. Now my behavior has changed, and I'm glad to say I'm an owner of a Fitbit now.
I've converted you. Excellent.
Yeah.
Helen, what about yourself? Has being involved changed your views?
I wouldn't say it's necessarily changed my views. Well, I say that I've always been a passionate advocate for devices. I think that they have been really useful. But I think since I've been involved in this project, I've actually been more passionate about it, and actually more passionate about the potential that it could have for diagnosis and treatment. So I'm really excited to be involved in it. I think the one area where I think I've learned is really sort of like being much more challenging about actually who actually has access to these devices, and being aware that there are groups of people that don't have access to devices for various barriers, whether it's technology, whether people don't really feel that they're that useful, whether they can't afford it, and for all of those things, so that we need to make sure that we can make sure that all of those people are included when we're shaping the project, which Tim's already talked about. So from that point of view, I think it's been big learning for me in terms of just being more aware of actually the number of groups and the health inequalities that could potentially happen if it was just focused on the people who do have the Fitbits currently right now. Yeah.
Brilliant. Thank you so much, Helen and Anwar, for sharing your experiences and your views and the insights. I think that's really, really useful. And it's nice to hear that you feel valued as well being involved. That's really nice for us to be able to hear that as well. So that's great. I can see loads of hands going up and loads of questions. So I am going to hand over to my colleague, Jackie, who will manage the next section.
Thanks, Myra. And thank you to all our speakers, Tim, Helen, Anwar and Myra, for your talks and input today. During the live webinar, we now held a question and answer session to allow attendees to ask any questions they might have and share their thoughts. The question and answer session isn't available in the webinar video to protect the privacy of participants. However, written responses to all questions and points raised are available in the report on this webinar via our website at the link shown here. You can find this on our personal monitoring data page. If you'd like to find out more about the BHF Data Science Centre and our work, please go to our website at the link shown here. You can also follow us on Twitter. Thank you for watching this webinar. We hope you found it interesting and we hope to see you at one of our events in the future.